Yeah, good morning. At the outset, I'd like to thank Dr. Chaitra for this opportunity to be speaking alongside the who's who of Retina. It's a great honor. So I'll be talking about Octa for DME monitoring. Does it really have a role? So these layers that are the readout layers that are Octa. These are the one of the commonest readout that we usually see in day-to-day practice now. So this we all know is the superficial plexus. This is the deeper plexus. This is the outer retina, and this is the choroid. So these four layers are the default layers what we see, and but the layers of interest today are the superficial plexus, wherein we can see these larger vessels, and this is the FAZ, and this is a DCP. This is a deep capillary plexus. We can see a very close knit of vessels over here. So we'll be talking about the changes in these layers that happen in a diabetic macular edema. So even before any changes happen, structural changes happen in macular OCT in diabetes. So we do get to see some changes that happen in Octa. So these are very early changes that do happen, like a change in the vasculature, a change in the FAZ as well. So we did publish a paper wherein we saw that over a period of time, with the severity, with an increasing severity of the diabetic retinopathy, we could see that there were changes in the FAZ as well as the changes in the capillary plexuses in different layers. So, but when we looked at these things with a statistical analysis, we found that when it goes to severe stages, the spacing between the larger vessels had increased, wherein we looked at the initial phases like a mild NPTR or something. The changes happened between the smaller vessels. And FAZ really didn't change much because these were the eyes wherein there was no macular edema. These were flat maculas. These were just the changes that happened over severity of diabetic retinopathy. And this is the inbuilt software in the machine what we are using, the OptoView. So this is how we see initially the dropout areas, the changes in the FAZ, and this is a color-coded map. The blue colors obviously mean less vascular supply, and the hotter areas represent a more vascular supply. And when we look at diabetic retinopathy with the macular edema, and if these two scans are given for a readout, we obviously tend to mistake these changes in the deep capillary plexus to be enlarged FAZ or a macular ischemia or severe dropout of vascular areas. But when we see these in combination with an UNFAS image, this is an UNFAS image of the superficial plexus. This is one of the deep capillary plexus, and OCTB scan. So whenever we are interpreting an Octa image, OCTB scan is a must. So when we see what section of the layer it is passing through, that gives us an idea where we are really looking at. And when we look at these cystic spaces, this obviously is passing through the areas of macular edema. So this gives rise to an impression that there is a capillary dropout, which is not. This is a comparison with an FA, the angiography. So we can see an aneurysmal dilatation here. This is a superficial capillary plexus. This is the deep one. So we know that aneurysms can exist even superficial as well as deep capillary plexus. So this particular aneurysmal dilatation especially is seen in SCP, not in DCP. So, but other aneurysms can be seen in the DCP, and we can see a change in the FAZ both in SCP as well as a DCP. Another case wherein we can see in the SCP as well as the DCP. And if you look at the morphological pattern of the macular edema, there's a subretinal fluid, intraretinal fluid. So obviously when the scan passes through this, the superficial plexus, it can pass through the layers of the retina, but once it comes to the deep capillary plexus, it has to pass through the areas of edema, so which gives rise to this kind of a scan. And aneurysms can obviously be seen in some scans wherein it passes through aneurysms. And severely deranged and disturbed macula, if you look at here, lots of cystoid spaces and hyperreflective material, and even there's quite a loss of parallelism. So when we look at an Octa, so it's quite a picture wherein we just feel that there is a loss of structure there. But once you look at a B scan and UNFAS, we get to know what really we are looking into. This is a case of a non-responding DME. If you look at the morphological pattern of macular edema, again, we can see the intraretinal, the intercystic hyperreflective material, lots of aneurysm here, loss of parallelism, and most probably drill also. This is a superficial Octa image as well as an UNFAS, and this is the deep. So we can see the irregular pattern of the vasculature on the DCP, and the similar thing reflects even on an UNFAS. So we get to know what really we are looking into ANFAS also really helps to kind of judge whether how bad is the DME and how much is the extent of the macular edema. So there were various papers which presented which showed that when there's a good response DME, the aneurysms were less, and when compared to a poor response DME in a deep capillary plexus, aneurysms were more. So this is again a correlation that was done by Lee et al., wherein they saw that in a good response DME, just the FAZ changes were there. There were some aneurysms, but when they looked at a bad response DME, they could see that in the morphological, the B scan, OCT B scan, the OPL was disturbed. So wherever the OPL was disturbed, so the cysts in the inner nuclear was obviously like they're communicating with the outer nuclear layer. So the same can be seen on a DCP layer. We can see a capillary dropout areas. So coming to the importance of DCP, now we know that DCP is extremely important for the macular edema as such, because more aneurysms are there over there, and it is a voluminous layer, 60 microns. The blood flow in DCP is extremely important because there is a synapse of bipolar cells and photoreceptor cells that happen here, and because OPL acts as a fluid barrier, the intracranial cysts which are present in the inner and outer nuclear layer are kept at bay. But once this is breached, they communicate, and it results in a non-responding DME. And DCP provides 15% of oxygen supply to the photoreceptors inner and outer nuclear layers. So disruption of this layered structure can easily predict the outcome of diabetic macular edema. There are other studies which showed that the areas of macular edema have more aneurysms when compared to the areas which do not have macular edema. So coming to macrosysms in DME, all the studies, they come to one conclusion which say that when there is edema, the aneurysms are more, and the two, they are more in the DCP. But when we look at an angiography comparison with an octa comparison, only 62% of aneurysms which are detected by fluorescein angiography could be detected in octa. That could be because of the difference in flows. There could be high flows, there could be low flows, there could be infarcts and various other things. So there's another study which showed that before and after Ozurdex injections, the dexamethasone implant, they did not really find significant changes in the SCP as well as DCP, wherein choroid they found that there's a little better visualization of the course architecture, obviously because of the decrease in macular edema spaces. But what they found was the changes were more in the parafoveal area, both in the SCP as well as the DCP. The other thing what we need to keep in mind is a pseudo flow. These are the artifacts that we see, especially the hard exudates. When the eye moves, the saccades that happen, they tend to project these hard exudants aneurysms as pseudo flow. So these are called suspended scattering particles in motion. So these are not flow areas, but these are the areas which do not have flow, but these are hard exudates or something which kind of give rise to a false impression of a flow. So this is a latest article which compared the Zeiss plexalite and AngioView. Zeiss plexalite is a SSOCT, this is an SDOCT. So what they had noticed, if you look at the scan structure here, it passes through the area which doesn't have a macular edema. So if you see the same area which passes through, there is a clear-cut capillary dropout. But when you look at this hyperreflective area, this passes through the intraretinal, the cystic space. So these cystic spaces are hyperreflective. So what they say is these have the suspended, the SS PIM. So they say that when there is capillary dropout, and when it passes through the normal retina, so this means that there is a capillary non-perfusion. But when it passes through the areas of cystic, it doesn't mean that there's a non-perfusion. It just means that there is SSPIM. And when they compared it with Zeiss plexalite with AngioView, they found that Zeiss plexalite is more sensitive to detect this SSPM when compared to AngioView. And there's another phenomenon that can happen when there's a macular edema. So the vessels do get displaced over a period of time. They kind of get pushed because of the intraretinal fluid. So we can see the disappearance of the vessels, then again reappearance of the vessels. We can see the vessels were not there here, but after the edema resolution, we can see the reappearance of the vessels. So this doesn't really mean that there's a vessel loss, there's a macular ischemia, but we need to look at the scans when there's a return of macular architecture. So there are studies which even kind of monitored the types of microorganism, or 1 year what was the hyperreflective microorganism which was there that remained to be hyperreflective, wherein the hypo ones they remain to be hypo. So coming to the features, what we need to really kind of keep in mind when we are interpreting an octa. So FAZ and vessel visibility can change once the macular edema decreases. That could be because of the remodeling of the vessels, as we discussed, vessel displacement and capillary changes, and even a change in the vessel flow velocity. And even the FAZ also changes because of the vascular changes secondary to DME, fluid shadowing, and loss of signals, and several other artifacts. So coming to the difficulties in interpreting octa in DME, it could be because of the differentiation and segmentation difficulties in anatomically completely distorted scans, projection artifacts, and there can be several other misleading features like edema and hard X-rays.
Sorry to interrupt, sir. The time is up. Need to conclude.
Yeah, I'm just concluding. Yeah. So to conclude, octa really helps in kind of prognosticating the macular edema, to checking out the microaneurysms and non-perfusion areas, and it could be a really helpful tool in the investigative modality, as well as basically the prognosis and the academic interest as such. Thank you. Thanks for the opportunity.